Very thankful that you've joined us here today as we're here to address an incredibly important topic of health disparities in multiple myeloma. My name is Dr. Joseph Mikhael. I'm a hematologist, and I have the privilege of serving as the Chief Medical Officer of the International Myeloma Foundation. So welcome to our site here at the IMF. And we plan to just take this next half an hour with you to share with you the topic of health disparities, and specifically within the African American community in multiple myeloma, and also to really focus on what research has just this week come out of our annual American Society of Hematology meeting, or the ASH meeting. This ASH meeting is the largest meeting of hematologists in the world. We were able to meet in person to a certain extent. A little over a third of us were there in person, and the rest were virtual. But we typically have about 30,000 people. We had about 11,000 people in person in Atlanta. And I can tell you in my role at ASH that it has been remarkable to see that over the last few years, there has been a greater and a greater interest in health disparities. And we have had more and more research presented in this area. And so I'm going to focus today in the area of multiple myeloma, which is our clinical and research and support group focus, because there were hundreds of other abstracts, of course, in health disparities. But there were about 20 abstracts just dedicated to health disparities in multiple myeloma. And so what I'm going to do over our time together is just share some of the highlights of those key abstracts, and then give you an opportunity to ask some questions. So there is a question and answer feature here, a chat feature. So feel free, of course, to send me questions as we go, and we'll spend about the last 10 minutes or so going over those questions. So let me start by just reminding us how absolutely important this topic is. We know that multiple myeloma is twice as common in the African American community. We know that myeloma, unfortunately, despite great improvements in survival over the last decade, we have not seen that same degree of survival improvement within the African American community. And we're going to be talking about some of the reasons why that is. But yet, I always like to speak of hope and positivity, is that we do know from various studies that when African Americans are given access to the kinds of treatments that have made such a difference in myeloma, that their survival can not only match Caucasian patients, but indeed exceed them and be better. So we have a goal line here that we know we can significantly improve the situation for Black patients. And so much of this research that we're going to be discussing today is designed to do that. And so I'm going to break all of these abstracts into just two parts, into two major buckets. Bucket number one is what I'm going to call the systemic problem bucket, and bucket number two is going to be the solutions bucket. So a lot of our studies were done to really assess the problem. You know, we're kind of built like doctors that way, right? The diagnosis always comes before the treatment, right? Before we can come up with a solution to the problem, we have to diagnose the extent of the problem. And there were many abstracts that tried to help us understand the extent of the program. And I would put these in three groups. So number one, things to do with socioeconomic status. Many studies demonstrated to us some of the things that we inherently knew but needed to hear in more fulsome capacity. For example, there was a really excellent study done in Boston that was looking during the COVID pandemic. Were there differences between African American patients, or even Hispanic patients and other minorities, and Caucasian patients with respect to whether or not they were able to access video visits, or did they have to just use phone visits during the pandemic when we weren't necessarily seeing all of our patients face to face? That in of itself is important. It reminds us of what is often called the digital divide, that there clearly was a difference, that there was a challenge in having more people see their physicians by video. And we know that although person to person would be ideal, that at least video, there is more of a human and a visual connection whereas in the phone, it's a little bit more distant. Furthermore, we saw a great study out of St. Louis analyzing the financial toxicity. As doctors, we talk about other toxicities, how chemotherapy can affect the hair or the blood cells or the kidneys or the stomach. But here we are talking about the financial toxicity. And sure enough, we saw in those that socioeconomic status very much influenced people's ability to be treated for their disease. Indeed, another study focused out of Milwaukee, focused within the Hispanic community, but showed unequivocally that the reduced benefit that many patients had seen compared to others, the reduced survival and outcomes of their myeloma, was directly related to their socioeconomic status. And if those could be overcome, then patients biologically could do better. So this first set of abstracts reminds me we have a problem. We have a very significant problem. It's multi-headed, but one of the heads of this problem is socioeconomic status. And if we're not willing to look at how that is built within our community, we're not going to be able to find a solution. The second area that was important to me within systemic issues was the diagnosis issue. I was really fascinated. I was fascinated by all of these abstracts, but I was particularly fascinated by this one abstract that came out of the Chicago group that looked at the differences between Black patients and white patients and how they were carried through to their diagnosis of myeloma, what tests they received to make the diagnosis. Myeloma is not a disease where it's just one simple blood test. Sometimes I say myeloma is kind of like a crime scene. There's so many bits of information from multiple areas, and the only way to understand it is to get all of those bits together. And sadly, sure enough, they showed that Black patients were less likely to have all the complete tests that we need to accurately make this diagnosis. This builds on what we know already and have seen historically, that there is a longer time from the signs and symptoms that people experience to their diagnosis of myeloma in the African American community than in the Caucasian community. And this study built on that and showed to us sometimes it's recognizing those signs and symptoms, sometimes it's starting those tests, but here they were showing to us that those tests were not completed. So half testing someone is not going to serve them well. We want to be able to provide the full array of testing. And so I think this is very important research that tells us about how important it is to allow access, indeed, to that testing. Which brings me to the third major area within the systemic research, which was access. Many have heard me say before, there are three big T's in myeloma. All three of these T's have led to improvement in survival in myeloma, using what we call triplets, which is to say 3 drug combinations or new drugs. Number 2 are transplants, using a stem cell or bone marrow transplant we know can improve patients' outcomes, and trials or clinical trials. We know that clinical trials have an impact. And so we saw research in all of these areas. There was a large study, even in the UK, actually, it wasn't all just American-based work, showing that minorities were less likely to be enrolled in not only clinical trials, but specifically now looking at using these new drugs that have changed the way we treat myeloma. They showed that actually the outcomes on those, when those patients received those new drugs, they had just as good an outcome as others, but they were less likely to receive them. And so again, it begs the question, why is it that we're not giving them that opportunity? And even there was another study looking at when people got those drugs. So there's a particular drug that came to market in 2015 called daratumumab, which has really been another an important addition to what we do in multiple myeloma. And this other group found a significant difference. This was a Canadian group looking at when people got daratumumab, and Black patients were much more likely to get it later in the disease course after several lines of treatment, not earlier on when we know it has a greater impact. So it's not just about getting the drug, it's about when that drug is obtained. And there's another source of disparity there, not only in getting the drugs, but in the timing of them. And then I found it very fascinating that a group in Georgia from Augusta looked at historically how many African American patients were enrolled in the key clinical trials. So, not just trials in general, although obviously that's a really important point, but they wanted to look at what we call pivotal trials. So, these are really important studies that ultimately lead to the approval of different drugs. And sure enough, there was a significantly lower number of African Americans included in those studies than we would have in the general population. As a side note, one of what I thought was really key moments of this meeting at ASH was a very well-known physician from Indianapolis who I know and I respect greatly. He is African American himself. Stood up at the podium and asked a question about why were there not more Black patients enrolled in this key clinical trial that we know is going to have an influence in blood cancers. And, this is an issue. In multiple myeloma, we estimate that roughly 20% of all myeloma patients in this country are Black. And typically, most of our large clinical trials have 4, 5, 6, maybe 7%. That's starting to change, and we're starting to see some improvement, but it clearly is a disparity. I'll share with you at the end what this same physician, Dr. Bihare, said about how we can overcome some of this disparity in clinical trials. So you've heard me talk about triplets, transplants, and trials. I'm going to suggest that we're going to be adding another T to that list of disparities in access to treatment. And the Arkansas group presented some excellent work looking at, unfortunately, the reduced enrollment of African Americans in CAR T cell studies. Now, CAR T cell studies are something I'm sure many of you are very familiar with, but maybe new to others. CAR T is an area of work that is probably going to really revolutionize what we do in multiple myeloma. This is where we take someone's T cells or a certain kind of white cell that can be trained, and we actually can literally train it to recognize someone's myeloma, multiply it in the lab, and then give it back to the patient. I know it sounds almost like a Star Trek movie, but it's what we're able to do now. And we already have one CAR T approved in myeloma and likely others in the near future. And already we're seeing this disparity in this really important area. So the first group of research studies I've lumped together under systemic problems that really are helping us frame the extent of this problem. And the problem is more than just a clinical trial. We all know that there is a systemic issue in our understanding in racism in this country, and we want to be able to find a way to overcome that. But I respect that so many of these studies are really trying to help us be aware of the extent of many of these challenges that we're facing, where these disparities are in the timeline of a patient's course in multiple myeloma, so that we can lead to now part two, which is the solutions. It's one thing to sit here and talk about the problem. You wouldn't want to go to a doctor who just says, well, I figured out your problem. Okay, well, great, Dr. Joe. What do I do about it? Oh, I have nothing to do about it. Well, we clearly have something to do here. And I'm going to suggest that some of these great studies are already wading us into that water. And indeed, I'll share with you some of what we're doing at the International Myeloma Foundation to not just talk about this, but to do something about it. There were two particular studies I want to highlight. One came out of Chicago also. The Chicago group was busy this year, that wanted to have a more inclusive prognostic risk score, recognizing that many of these tests are not as easily available to African Americans and other individuals at risk in the community. Instead of using a scoring technique that we use in myeloma, what's called the revised international staging system, where the majority of the patients in that system indeed were white, said, well, can we use a system that would be more inclusive and more accessible to people and still have the power that the RISS has in predicting prognostically how patients are going to do? And so they created one, and it's really quite impressive to see that this kind of thinking, if there's anything you learn from us today, it is hopefully that there has to be a change in thinking before there's a change in action. We have to realize that this is a problem. before we're going to make a difference. And so I really commend the Chicago group and what they've done. I was also particularly interested in another study where a group looked at how we can use real world data and information about patients to generate better clinical trial sites. One of the solutions to clinical trials is not just going to go to the same places we do all these trials and say, you must include more minorities within your trial, but we want to be able to do so in a way where we're going to where people are. Right? Part of the challenge of getting on a clinical trial very often is the travel that someone may have to get to it, the lack of understanding of who that is, trust in that individual. I mean, there's a whole series of reasons. Trust in the medical community. We're living in a day of misinformation and fear, and we want to dispel that. And so they had found many sites that could potentially be opportunities for clinical trials in more within the community setting. And I've said this, and for those of us here who help run clinical trials, for industry that helps support clinical trials and creates them, for all of us involved in this, we have to start thinking beyond just the major metropolitan centers, but specifically in areas where we know people will have access to them. On that subject, I mentioned earlier, our friends in Indianapolis came up with something that they call DRIVE, which is an acronym, and I'm going to repeat it because it was so beautifully stated on Twitter a few days ago when we were at ASH, which was D, diversity officer. They are suggesting that all clinical trials have a diversity officer that can look and understand and help guide the process. R, that trials get ranked. And nobody wants to be a zero, right? That there's a ranking with respect to their inclusivity in the clinical trial. I, this is an individual phenomenon, that we all have a role to play here. No matter what piece of the puzzle you're involved with, all of us have a role here to recognize the significance of this and to want to ensure that the best care get to all of our patients, independent of race, independent of gender, independent of ethnicity. We want to be as inclusive as possible. The verification of those goals, that there has to be a monitoring system and have people met their targets, have people met what they're planning to do when they open a clinical trial. And then the last one I thought was important too is enhanced training for all involved in the trial, whether they're a clinical trial coordinator or a principal investigator, because very often we need to understand and listen. And this is part of what I believe in so much, what is often termed cultural competence, where we make sure as healthcare providers, whether we're physicians or nurses or pharmacists or whatever role that we have, that we are speaking in a way and communicating in a way that is going to be of value to the individual who's listening to us. So in these last few minutes before I dive into some of the questions that are coming in, and thank you for those who are entering those questions, let me assure you that at the International Myeloma Foundation, this is not just something we talk about, this is something we do. We've created what's called the Empower Project, capital M standing for myeloma-power. And the concept here is we want to empower patients and their communities to change the course of myeloma. What I mean by that is that the current course of myeloma, based on all that I've just shared with you, that has been recently updated and research presented in the last 3 or 4 days, is not an appropriate course. This is not acceptable to me. Black patients in this country can have significantly better outcomes than they do, can live longer with this disease and are not, because they don't have access, because the diagnosis is delayed, because they're not given the same opportunities that others are. And so we've created this program, and with this program, we are already embedded within the whole of the country with over 160 support groups. And we go in with this modality of, on the one hand, diving deep into the community, both medical and non-medical, working with medical organizations like the National Medical Association or Black Nurses Association and others, and with local cancer centers to raise awareness around myeloma, to bring people to a website where they can learn a toolkit of understanding, so that if they have signs or symptoms that could be myeloma, that they can go to their doctor and be able to get tested for this to make sure that it's not being missed. But that also we embed ourselves within the non-medical community to raise awareness within the fraternities and the sororities and so many other ways in which the religious community and others, so that people can understand this. We can take a bit of the stigma away, So we can know that myeloma is indeed at greater risk. In fact, one of the studies I hadn't mentioned yet from this great meeting was the PROMISE study, which was the largest screening study of African Americans yet done in this country, that showed that the rate of the pre-myeloma condition, something we call MGUS or MGUS, which is something people have before they have myeloma, is twice as common as population. Up to 10% of Black individuals over the age of 40 or 50 will have this, and maybe even higher if we look for it very meticulously. And so this is clearly something that we want to raise awareness around so that the diagnosis can be made earlier. A British study recently showed that the average myeloma patient goes to the doctor 3 times with signs and symptoms of myeloma before the diagnosis is made. And that leads me to the second arm of what we're doing in Empower. So 1, deep community involvement. 2, we are working within the primary care community, teaching primary care doctors about the early and accurate diagnosis of myeloma. And then indeed beyond that, we work within the hematology oncology community. Our nurse leadership board and now a group of physicians are creating best practices to help us understand these concepts, as I've mentioned, of cultural competence. And as we now are going from city to city, assessing the need, knowing every city is different, seeing how we can make a difference in partnership with the local community and with the local cancer center to try and improve both the short-term and long-term outcomes of African American patients. That's our mission in Empower, is to improve the short and long-term outcomes of myeloma patients. So that's all I'm going to share in terms of my didactic talk. There's so much more that I could say. I can see the questions pouring in here, so I'm going to try and do as much as possible a rapid fire of these questions that are coming in. For all of you who are saying hi, Dr. Joe, hi. Thank you for your kindness, and I really, really appreciate it. And I'm thankful that you are here. Someone asked, what is the I in DRIVE? It was individual. It was a recognition that each individual, all of us, have a role to play within that. So please make sure that as you're listening today, you recognize that as well. Here's a great question that says, I understand in the iStop trials, researchers went out in the communities to recruit them to the trial. Will we get to a point where U.S. researchers reduce barriers by going into communities? It's an absolutely brilliant question. And so indeed, for those of you who may not be familiar, iStop was the largest screening study in the history of myeloma, where almost the whole country of Iceland essentially was screened. Over 80,000 people consented so that we can understand myeloma better and this pre-myeloma condition that I mentioned. They had 4 oral abstracts at this last ASH meeting. Just incredible work by Dr. Sigurdur Christensen and Dr. Brian Dury, of course, the chair of the IMF, in conceiving this idea and carrying through with it with multiple partners along the way. But there are now, as I mentioned in the PROMISE study, and our colleagues in North Carolina are soon to embark on a similar study where we want to understand this better within the African American community, because Iceland represents Iceland, of course, but the diversity is not there as we would want to see in places like North Carolina or in many other places where we can try and learn that information. And indeed, a big part of that is going to be going into this community. There have been so many barriers that have been set up. Barriers within our hearts and barriers in our hands and barriers with concrete. A whole series of barriers have unfortunately restricted people's access to the best care that they could obtain. And part of what we're trying to do with Empower, with the help of individuals like even the one asking this great question, is to try and overcome those barriers. Lots of great questions here coming in. I know some of you are asking questions, specific myeloma questions. I think for time's sake, I won't get into them as much about what to do after transplants and so on. But I do appreciate a few comments here about where we can go in the community, including going into the barbershops, going into the religious community, into churches, into many community health centers, and that indeed is absolutely part of what we're seeking to do within the Empower project. So here are even more questions coming in about access to drugs. this is a huge issue, and how can we overcome that? How can we make sure that they're more accessible? Well, as I've often said, whether it's triplets, transplants, trials, and ultimately CAR T, there isn't one solution to it. It isn't just about insurance. It isn't just about the cost per se of the drug, although that's obviously a huge part of it. There's so many areas that this requires policy intervention. This requires us in medicine wanting this and finding ways and being creative in the way we do it. It's going to take support from the industry, and it's going to take support from the community. So at the highest policy, governmental levels, within the medical community, within industry, and indeed within the community at large, those four stakeholders have to be able to work together if we're going to overcome some of these great problems that we see within the access specifically to drugs and treatments like a stem cell transplant and CAR T. Did you see the perception that patients who die while on trial from other comorbidities or from multiple myeloma being too advanced is viewed as dying because of the clinical trial? Similar to, I understand. Oh, I see the question. So we have an important topic that's raised here in comorbidities. So what do we mean by that? What we mean by that is very often when someone is diagnosed with myeloma, because this is a disease that tends to be diagnosed as we are getting older, the average age of diagnosis is about 70, although it's 65 in the African American community and about 64 in the Hispanic community. Often people can have other comorbidities, as we say, or other conditions. In particular, within the African American community, we see diabetes or heart disease or kidney dysfunction. Of course, that can be in all patients. And that can often influence our discussion today for several reasons. One, it can influence the diagnosis. And very often, a Black patient may be told, well, you know, you have diabetes, so I'm not worried that your blood count is a bit low, that your hemoglobin is a bit low, or that your kidney function is not quite right, or that you're having numbness or tingling in your fingers and your feet. It's just from the diabetes. And diabetes can actually be mimicking multiple myeloma. It can often influence the actual treatments that are given, because some of the treatments may be withheld or dose reduced or avoided because of those things, because of the neuropathy or because of those other comorbidities. And this is part of, I think, the greater discussion of recognizing that when we build things like clinical trials, that we don't be so restrictive that we're not reflecting real world individuals. And so we have to be more careful in the way we design them so that we're not as restrictive as others may wish to be. Now, I know it's hard to believe that our time is essentially gone. I would love to answer all of these questions that are here, but I will say for those who have submitted questions, we can work on getting these answers back to you. And please come and learn more about what I've described today. And there are multiple ways that you can do that, even here on the Facebook page, of course. You can also go to our general website at the International Myeloma Foundation, which is myeloma.org. Or embedded within that, of course, is our Empower website, Empower, with M, the word power, .myeloma.org, where you can hear more about our activities and what we're doing and how we are so committed to this topic. I'd like to thank our sponsors for this event. There have been many who have supported us in doing this and continue to support us in multiple ways. Without you, we couldn't do this. As you can tell, I'm slightly passionate about this topic, and I'm surrounded by an amazing team of individuals that work with me in the IMF and beyond, and I'm so thankful for them and for what you're doing. So please stay tuned. There will be more of these with time. For those of you who wish, there is going to be a Best of ASH tomorrow that our chair, Dr. Dury, will be presenting. You can see more details about that on our myeloma, on our IMF website at myeloma.org. Thank you again for joining us tonight, and I hope everyone will take to heart some of the discussion that we've had about these health disparities and do our part to try and overcome them so that we can give the very best to all of our patients. Thank you very much.